Always wondering what you see on your OCT scan, but you're just not sure what it is? Well, in this video, I'm going to show you how to interpret the red disease in OCT scans. So here's a list of some factors that will contribute to a red disease. Having the incorrect age, segmentation errors of the retinal nerve fiber layer, or I'll just refer to it as nerve fiber for short, having high refractive error, longer or shorter than normal axial length, cyclotortion, peripapillary atrophy, and artificial increase in the nerve fiber thickness. So the first factor, age. Just like the visual field, OCT will use the measurements from the patient and match that to the general population with the same age. That's how the machine knows what is normal in a patient. Rule of thumb, as you get older, the nerve fiber gets thinner. As I said before, incorrect date of birth could cause abnormalities in OCT scans. Segmentation errors. So a reduction in signal strength or image quality that is due to media opacities such as dry eye disease, corneal opacities, cataract, vitreous opacities, or even optic nerve edema. In a serous platform, anything below a 7 value, that can lead to errors in nerve fiber thickness, so that should be expected. And this can be seen in a TSNIT thickness plot. Basically, that stands for the T's for temporal, S superior, N nasal, I inferior, and then back to temporal again. Okay, you'll see that in the scans I'll show you. Decentration of z-axis leading to truncation of image. I'll show you an example so you have a better understanding. So first off, we're going to start here. This is the fundus photo. Here's the right eye, the left eye. As you can see here, a lot of haze, vitreous opacities, cannot make out what the optic nerve looks like. So don't expect to have a good quality scan image with the OCT for this eye. Looking at the left eye, clearly you can see perfect clear image, but looking at the optic nerve, I'm getting the glaucoma vibes just looking at this, right? So look at that optic cup, it's pretty big. Follow the blood vessels, you can see the depth of it. We're going to take a scan and see what exactly is going on here. But remember, first, always look here at the date of birth. Make sure you have the correct age, because if not, then everything's just pointless from there on. And then look here at the signal strength. Like I said before, in the right eye, you're not going to have that great of an image quality, so 6 out of 10, which is fair anyway. Here is a perfect, excellent image quality scan, 9 out of 10, as you can saw there with the left eye. That was pretty nice clear image. Now going into the scan itself, here you see lots of red here, red here. So all this is what we call the red disease. So this is up to you as the optometrist to make sure that what you're seeing is actually true, right? Looking here at the nerve thickness map, you see here there's black areas here. Those are missing parts. So the OCT thinks that there's absolutely nothing here, as in absolute nerve fiber loss. And you know that's not true. There's always going to be some cells in each layer. It's not going to be like a clean slate. So this is just because of the vitreous opacity that it couldn't detect the structures of the retina and the nerve. So that's why it's having like shaded areas. But you see that translate here in the deviation map, right? Follow the outline of the same error, all this red here, showing that there's a nerve fiber loss because it's just parts missing, that's all. So this is an artifact. It's not a true nerve fiber loss. But thankfully, that only a portion of that error is taken into calculation for the nerve fiber thickness. And I'll show you in the plot soon. But here and over here, you can assume that that is true nerve fiber loss. Looking at the neuroretinal rim, which is between the border of the cup and the disc, you can see that here there's loss here, and it's not like even all the way around, right? So that can be seen here. If you look at the solid line and the inferior part, you'll see that there is a dip here. in the inferior region. Compare that to the superior part over here, whereas in the yellow region, you see that the inferior is actually lower than superior. And in class, as you learn about the Ising rule, that inferior for eye, superior, nasal, then temporal, right? It should follow a decrease in order, meaning that inferior should always be the thickest part. But here you don't see that. Here, inferior is actually thinner. So there's a violation to that rule. And you can assume here that glaucoma is at play. Looking here at the left eye, you'll see true nerve fiber loss, because this is a good quality image scan. The left eye image was clear, no errors being seen in the thickness map. And then here you can look at the chart value. You see here in both in the right and left eye, the optic cups are large. And let's see. In the disc area, I would say a moderate. But you can see here as well, nerve fiber thickness loss. Definitely glaucoma is at play here. Looking at the nerve fiber thickness map, remember that error we saw in the thickness map and as well as the deviation map. You see here in the inferior portion, there is that dip there, right? Nearing 0 microns. Like I said, you're not going to have 0 in anything, right? That's a true error. There's always going to be some residual cells, glial cells, non-functioning ganglion cells. There's going to be something there, so it's never going to see 0. So you know that's just a flat-out error. And then the rest is going to be translated down to the quadrants chart and then to the sector chart for clock hours, for each clock hour. And here you see in the circular tomogram that the black arrow that we saw in the thickness map, that is right here, piece is missing. So here, this is just another OCT scan separate from the one that I shown you before. I just want to show you an example of that decentration of the z-axis where you have truncation of image. So here your structure is cut off, right? And you'll see that's mostly with patients with head tilts or even large cupping and other diseases as well, right? Where you cannot fit the whole structure because of like extremely different heights of structure. We can't fit all that into a single V scan, right? Sometimes it's very difficult. So you really need to see why you're seeing a red, where is that coming from, and reason out. High myopia and longer axial length is typically associated with thinner nerve fiber thickness. Opposite is true for hyperopic patients, and shorter axial length that can show increase in nerve fiber thickness. Effects of refractive error and axial length that can induce ocular magnification. Increase in myopia is associated with more temporal shift of arcuate bundles, and I'll show you an example of that. Increase in hyperopia is also associated with more vertical angles, so it's coming in more vertically into the optic disc. So here we're seeing a fundus photo. Again, it's the right eye and left eye. Looking here at the optic nerve, you can see that it is tilted. Follow the blood vessels here, you can see that it's kind of dragged, straightened. Here is a flat portion here of the optic disc with that scleral expansion or a myopic crescent. So this is definitely a myopic fundus. And the same thing here you're seeing with the left eye, that myopic crescent. The arcuate bundles is always going to follow the blood vessels, right, the arcades. And you can see here that it's kind of shifted more temporally, right? And over here too. Looking at the scan, the nerve thickness map, you'll see here when you follow the blue arrow, you see the shift of the arcuate bundles more temporally. The black arrows indicate of the general population, so what it should be normally in this position. Looking here in the deviation map, you see here red disease, right? As well as the left eye too, red disease, showing that there is nerve fiber loss. But is it really a true nerve fiber loss? Well, we know here that it's been shifted, so no, it's not true. There is nerve fiber, but it's just not in the area that it usually is compared to the general population. So the machine thinks that it's just thinning here, but we know that it's not true thinning. So that's why you have to really analyze everything here. The same can be true with the left eye, right? So here is the arcuate bundle, but with the general population is usually in this area, but it's not, so it thinks that there is a loss there. When it comes to optic disc, the OCT manufacturer don't use normative data to compare with for the disc. I don't know why this is. If you do know, please let me know in the comment section down below. The rest of the values here is shaded in gray as well. The reason for this is there is insufficient data or not enough number of subjects to compare it to with this optic disc size. So that's why everything here is shaded gray. And then you see that translate here gray too as well, and the neuroretinal rim. Remember I said too, with increase of myopia and longer axial length, you're going to get induced magnification. Well, in this case is induced minification. You can see here in the right eye because you have a small disc and optic cup is small too, but this is what the myopic fundus. Usually you don't see that with myopic, right? Because everything's being stretched out, thin out, but here everything looks smaller, is induced. And you can see here lots of neuroretinal rim in both eyes. And you see here too, when you're looking at the values too, like 400 to 500 microns, a lot of thickness there. Going into the nerve fiber thickness plot. So this just shows you that temporal shift. So you see here, this is where the actual arcuate bundle is in the superior temporal area, and that's why you're seeing is in the green area here for the right eye. Whereas here the black area is showing the general population. Usually it should be in that area, right, to follow that double hump. And the same is true for the left eye, showing that temporal shift. And everything here is just being translated in the rest of the graphs. Cyclotorsion. So cyclotorsion is rotation of eye around its visual axis, and that can change in superior temporal and inferior temporal nerve fiber thickness. The shift in peaks will lead to false positive probability plots in both that neuroretinal thickness plot and as well as the nerve fiber maps. Again, this can be seen too with head tilts, skew deviation, and fourth nerve palsy. So here we just have a fundus photo of the right eye. I just want to show you the proper alignment of what it should be between the optic nerve and the macula. So just here it should be like this. Here we have macular thickness maps superimposed on the OCT fundus scan. Looking here in the right eye, you see the optic nerve is higher than the macula. So this is a rotation, right? A torsion of the eye. To have this in the proper alignment, the eye will have to rotate inward, right, to that direction, more nasally, right, towards where the optic nerve here is, so that it can straighten it out. So for it to go inward, that means it was already out. So this is actually an cyclotorsion of the right eye. Looking here in the left eye, you see this is the proper alignment. It's not going to be a completely straight line, never is. There's always some degree of rotation there. This is normal though in the left eye. If you look here, you can see because it's being rotated, the arcuate bundle inferiorly is being shifted to other parts of the nerve fiber around here, right? Remember, it's always thicker in the inferior part. So there is already some nerve fiber over here, but because the arcuate bundle is being shifted, it's added on. So that's why it is elevated here, thicker than usual. And the red is just showing that superior temporal shift and leading to a thinner side more superiorly. So that's why it's red. Okay, it's just showing here. Peripapillary atrophy. So interference with segmentation of the nerve fiber layer in time domain OCT. So that's usually a problem with that type of OCT. An example of that OCT is stratus. Inability of software to align with scans along the RPE border. Because there's no pigmentation here, it's all atrophy, so that's why it's having a hard time. And that can lead to adversely affects the segmentation of the retina layer. But fortunately, with the spectral domain OCT, this is no longer an issue, or that great of an issue, I would say. So artificial increase. So let's look here at the fundus photo first. Let's start with the right eye. Oh, we always start with the right. Look here, tortuous vessels. Okay. Nerve is white, it's pale, looks dead. Look here, you see a sheen, some kind of gloss, like something's there, right? You don't see that in the left eye, but left eye is also pale, right? It's a dead nerve. But here the vessels are not tortuous. So let's see what's going on in the OCT. Okay, so you see the red disease. Let's see if it's true red disease. Let's see what's going on here. In the thickness map, you see definitely there's loss, great loss of nerve fiber. And that can be translated here, right? All around here, nerve fiber loss. But it's weird because it's like you see a lot of loss here, but I feel like there should be more. But we'll see. Here in the left eye, yep, it looks more dead than the right eye, and you see that too with the deviation map. Lots of red, lots of nerve fiber loss, and this seems to be true. Let's keep going. All right, the neuroretinal rim, the red eye is in the white part. Why is that? Let's see here. Right, lots of neuroretinal rim in the right eye. Great, because the cup is small. Look here. Cup is like less than 0.1. It's really tiny, so you see lots of the neuroretinal rim compared to the left eye, where you see more like in the normal range, in the what's like inferior nasal part, so around here, compared to the rest, which is like very thin. So that's what's happening there. Yeah, and let's look at the optic disc. You see here, so this optic cup, the optic cup size is not normal for the disc size of 1.8. This is really small. Yeah, it is. Yeah, there's something's not right. Looking here at the nerve fiber, you definitely see that there is loss. There is loss. More so in the left eye than the right. And everything here can be translated down to with the quadrants and the clock hours. And you look here at this A scan here of the optic nerve. The right eye is elevated. The left eye, you have that usual cup in. It should be like this. It should always be some sort of cup in. So why is it? Why is it like flipped? Why is it elevated? Well, that can be due to that, probably that sheen that we saw. It's probably like a coating on top of that. And what this is exactly is optic nerve gliosis. So this is actually glial cells that we're seeing here that has been proliferated on top of the optic nerve. Usually when you have dead cells or like injured cells, you'll see that proliferation of glial cells. Think of that as like scarring tissue, pretty much. Similar to ERM in macula, perfect example. Here, another example of artificial increase. Looking here at the fundus photo, I'm just knowing disease. I know this is a myelinated nerve fiber. It's around here, inferior nasal to the superior, wraps around there, and you can see that translate to and the thickness map around here. Going to the deviation map, red disease, chart red disease. Is it a true red disease? Let's see. Here where it is thick, because of the nerve fiber, you don't see any loss, but you do see loss here and here. And the same thing over to here and here. So if you look here at the nerve thickness map, you see in the right eye it is elevated right here, more nasally, right? And that can be true here. So is this like a true increase of like nerve fiber over here? Well, no, it's just because of the myelinated nerve fiber that's just been added on. So it's given that artificial increase, right? So that's what's seen here and here. That's basically it. So this is pretty much straight over because that is pretty evident to see. Looking at the fundus photo, it's pretty hard to see what is going on here. The nerves look small in both eyes, but it kind of looks swollen too, right? So it's pretty hard to tell by just looking at the fundus map, is this an optic nerve hypoplasia or a papilledema? Looking here at the thickness map, you see that the nerve fiber is like a figure 8, if you see that. It's like a semicircle on top and bottom. Usually it's more like an arcuate shape. So why is that? You see the same thing too, the same shape with the left eye. Going down here in the deviation maps, no sign of nerve fiber loss is pretty good. Again, here when I mentioned everything's in gray, like I said, not enough data because look at this, the disc is so tiny, insufficient data, everything's shaded in gray, even the cups are tiny too, alright? So far, everything is pointing towards optic nerve hypoplasia. Look at the nerve fiber thickness. Perfect, like this is following the double hump, there's no sign of a nerve fiber loss. This is definitely optic nerve hypoplasia, no signs of swelling. Looking at the fundus photo, this will scare anyone because first thing you pop in your head, you think glaucoma, glaucoma, glaucoma. This is like probably screaming glaucoma at you. Or sometimes they can just be a physiological large cupping, large optic nerve. Right, so we have to see if this really is megalopapilla or glaucoma, and that's what we do OCT to figure it out. So looking here at the nerve fiber thickness map, you see you get that arcuate like you should. Look in the deviation map, it's showing nerve fiber loss, superior temporally and inferior temporal. Okay, so why is that? Well, let's look at the fundus photo. You can see here how the blood vessels are entering the disc, right? You see how it is kind of to the side, everything shifted. So that's probably what is going on. There is a shift of that arcuate bundles, right? Leaving to one side more thinner than the other. So that's why the machine thinks there is a loss there. And you see like really huge optic cups, right? So you're gonna have a depressed neuroretinal rim thickness. And if you look here, right, optic cups, the CD ratio is large. Even the disc is large, right? So this is pretty normal. When you have a large disc or nerve, you're gonna have a large cup too. This should correlate together. And by looking here at the nerve fiber thickness, there's no sign of nerve fiber loss. So yeah, it's not saying glaucoma. It's definitely megalopapilla. All right, so basically that's how you will follow or analyze an OCT scan. You have to have a routine down if you want to be comfortable with this. It's always good to have a systematic approach. So make sure, number one, the age of the patient is correct, right? Because if not, then everything, what's the point? You just throw the paper away. All right, and then next, signal strength. You want to make sure you have a good image quality. If it's poor, like 2 or 3, right, you know that it's not going to be reliable. There's too much artifact, too much errors going on. Again, check the refractive error, especially when you have a high refractive error patient. You want to make sure if that's going to contribute to how the structure of the nerve or retina is, as well as axial length, right? If you have that available, yeah, just look at that too, just to make sure what is going on. Analyze the optic disc thoroughly, like I showed you so many examples. You want to look at that nerve fiber thickness map, the deviation map. You have the neuroretinal rim thickness map, as well as the nerve fiber thickness plot there. And then you can look at the value chart. And then you have the quadrants graph and then the sector graph, just to want to break it down even to the clock hours. You have all that. Everything should correlate. And then you should use whatever you see there on the OCT. You should always look back at the fundus photo. Just keep going back and forth. Just make sure that everything ties together. It should make sense. Recognize that ocular disease can create the segmentation error. And if you're following up the patient, make sure that subsequent scans, just check to see if those show any changes or progression of the disease. Right, so that's basically it with OCT. I got all this information from reading this really good article. It's called Avoiding Clinical Misinterpretation and Artifacts of Optical Coherence Tomography Analysis of the Optic Nerve, Retinal Nerve Fiber Layer, and Ganglion Cell Layer. It's a really good read, check it out. But I pretty much summarized it here in this presentation. Alright, so that is it. If you have any questions, just please leave it in the comment section down low. Smash this button if you like it, if you learn anything, and subscribe to my channel. I'm going to be coming up with more optometry related videos. Let me know what topics you want me to talk about. Open to anything optometry related. Alright, thank you very much. Have a good day.